who are sexually promiscuous and the intravenous drug users can also spread the disease. And also, you're at a higher risk of getting the HIV infection if you are getting blood transfusion. So for the community factors, if this high community viral load, it increases your chances of getting the disease because there might be untreated disease in the community, and also mother to child transmission is very high. Also, lack of male circumcision and high prevalence of STIs and commercial sex work increase the risk of getting HIV. So this is the morphology of the HIV virus. You can see that it has membrane glycoproteins, the GP120 and GP41, which it uses for attachment and for fusion. And we can also see it has it also has the cell it has membrane, and it also has the capsid, and inside the capsid we have two strands of RNA virus, and we also have the integrase enzymes, and we have the reverse transcriptase enzymes. So these are the stages in viral replication. So the first step is that the virus attaches to the CD4 receptor using the GP120 protein, and it also binds to the co-receptor, which can either be CCR5 or CXCR4. And then there's fusion, which allows entry of the capsid into the host cell. And then once inside the host cell, the virus undergoes reverse transcription, in which the RNA is converted to DNA, and then it's integrated into the host DNA, and then okay. So and then from the proviral DNA undergoes transcription and then translation to form the viral proteins, which is then cleaved, and then assembly occurs and the virus is released. So here is a pictorial of the same, the process that I've just described. So you can go through this once I send you the slides. So the phases of infection, there are three. The acute seroconversion, the latent stage, and then AIDS. So in acute seroconversion, the infection is established and this proviral preserver created, and then the person initially has a high viral load, and then the CD4 count drops. So after some time, there's appearance of antibodies, and there's also CD8 responses. And then the viral load drops to a steady state. But of note is that it doesn't go back to the initial number before the infection. And then this phase may take a few weeks up to several months, and these symptoms occur in about 50% of people. And then in the asymptomatic infection or the latent stage, there are few or no signs. So the person presents with few or no signs for a few years to decades. But of note is that this ongoing viral replication and the immune response is effective and vigorous. Then the viral load persists at a steady level, and also the CD4 count steadily declines. And then the last phase of infection is now AIDS, where the immune system is damaged enough that opportunistic infections develop. And then of note is that the CD4 count is less than 200 cells per microliter, and the various opportunistic infections can be used to stage AIDS. So this is the natural history of HIV infection. So you get the primary infection, the clinical latency, and now the AIDS, where they are opportunistic diseases. On the left, you can see the CD4 count, and on the right, you can see the viral load. So the clinical staging of HIV/AIDS, this is according to the World Health Organization. So there are 4 stages. In the clinical stage 1, the individual is asymptomatic or may present with persistent generalized lymphadenopathy. And in the clinical stage 2, the person has moderate or unexplained weight loss, usually less than 10% of the measured body weight or the presumed body weight. And the person also has recurrent respiratory tract infections. And the person also has the diseases listed there: the herpes zoster, angular cheilitis, recurrent oral ulcerations, papilla, pruritic eruptions, the dermatitis, and then the fungal nail infections of the fingers. In clinical stage 3, the conditions where a presumptive diagnosis can be made on the basis of clinical signs or simple investigation. So if the person has if the person has severe weight loss, where the person has lost more than 10% of the body weight, or the person has an unexplained chronic diarrhea for longer than 1 month, the person also has unexplained persistent fever, person has oral candidiasis, oral hairy leukoplakia, and pulmonary tuberculosis that has been diagnosed in the last 2 years, and severe presumed bacterial infection, that person, a presumptive diagnosis of stage 3 HIV infection can be made. And in conditions where the confirmatory diagnosis, where the confirmatory diagnostic testing is necessary, is if the person has unexplained anemia, to rule out other causes, if the person has neutropenia, where the cells are less than 500 cells per microliter, or if the person has thrombocytopenia with less than 50,000 platelets per microliter for more than 1 month. So in the clinical stage 4, there are all these diseases which are AIDS defining: pneumocystis, pneumonia, pulmonary tuberculosis, Kaposi sarcoma, the central nervous system toxoplasmosis, cryptococcosis, extrapulmonary cryptococcosis, and then disseminated non-tuberculous mycobacterial infections, chronic cryptosporidiosis with diarrhea, and recurrent non-typhoidal salmonella bacteremia. So if a person develops either of these infections, which are AIDS defining, then the person can be staged as stage 4 infection, which is basically the person has AIDS. Yes. So that has been that was my presentation. I now welcome Flavian to take over.
I'm waiting for the host to allow me share my screen. Okay, so we can continue. I'm Flavian Burure, and I'll be taking you through the management of HIV and AIDS and the opportunistic infections that come with the HIV. So, in this, when in the management, we are going to cover what you get in your history. Also, we'll cover the history and physical exam. Then we will cover the diagnosis and then the treatment of HIV. Then we will also go and cover the opportunistic infections and how they are managed. So on your history, my colleague has gone through this staging. So on history, you will just be looking for predisposing factors. So you look at the person's occupation, if it predisposes them to being getting HIV. You will also look at the high risk patients. You look at those people who reside in very prevalent areas. When they present to you, of course, they'll present in a particular class of WHO classification. So either classified as stage 1, 2, 3, or 4. But again, you have to come up with these predisposing factors. So once you have taken your history and you are suspecting that this patient is a HIV patient and they are under stage 1, 2, 3, or 4, depending on how they will present to you, you will go ahead and now investigate them for the diagnosis. So for HIV testing services, it should be voluntary. The patient should be willing to do the test, and then you should assure the patient that the test is done in a confidential manner, that because there is still stigmatization of HIV patients, so you assure them of confidentiality. Then there is counseling. So counseling, you do pre and post counseling. In pre-counseling, you explain to the patient what the test is, what are the possible results, and you also explain to them what the results mean. So if what result will be a positive and what result will be a negative. Then post counseling, now you cancel them depending on their results. So if they have a negative result, then you will affirm them on the ways to protect themselves from contracting the disease and protecting their partners if they are married or sexually active. And also if they are positive, you will now go through the attachment part, where you attach them to a facility or a group that will help them cope with this treatment of this disease. So on testing, there are virological tests and there are serological tests. Serological tests usually are for screening. Mostly you confirm with the virological tests. So serological tests can give you a false negative, especially if the patient is on the window period. So then you can go do the virological tests. And again, so when you do these tests, then it comes out positive. Now you'll want to cancel the patient on the treatment. So before starting them on the treatment of HIV, which is what we're going to talk about, you will tell them the goal of the treatment. You will talk to them that it's a lifelong therapy. They do not get to stop their medications. And then you will tell them the importance of adherence to these medications, when and how to take the drugs, and the possible side effects and how to recognize them. Then you tell them that if they recognize any side effects, then they should go to the facility for their drugs to be changed or the side effects to be managed. So on antiretroviral therapy, it has transformed HIV from a progressive illness to with a fatal outcome to a chronic manageable illness, in that most patients who are on ART live live longer than was presumed before, and they do not develop very many opportunistic infections when they're adhering to their drugs. So the goal of the treatment is to reduce the viral load to undetectable levels, improve the CD4 count to prevent the opportunistic infections, to improve the quality of life of the patient, and to reduce transmission of HIV. So this reduces the community burden of the HIV. So there are different classes of drugs that are used. There are NRTIs, and I've listed for each class the various drugs that we use. Of note is that recently we've been using dolutegravir, that is a recent drug that has gained a lot of use, as we will see in the regimen that we are going to give. So in the eligibility criteria for ART is that all individuals with confirmed HIV infections are eligible to ART, antiretroviral therapy, irrespective of their CD4 cell count, the stage they are in, their age, or even pregnancy or breastfeeding status, or the risk group. Any person, once you confirm that the person is HIV positive, then you start them on ART. And the timing is that you start them as soon as possible. So within 2 weeks is allowed. Uh, you start them as soon as possible, but within 2 weeks of diagnosis. So the criteria for readiness is just the baseline assessment for the various drugs affect various systems differently. So you'll do the baseline full hemogram, LFTs, and renal function test, because these drugs are metabolized and they are excreted in in the liver and the kidneys. So we want to know if the patient is if the patient's renal or liver function is normal before you give them a drug that will end up suppressing their already diseased organs. So a baseline CD4 count is just to give you a baseline on where you're starting, and then it's used to monitor the level of treatment of the patient. So if the patient is adherent to their drugs, then their CD4 counts will keep improving. A baseline viral load is also for monitoring, and yeah, it's also for monitoring. Usually, currently we use the viral load rather than the CD4 count for monitoring of the patients. So the baseline assessment is just to allow you to give appropriate medications to your patients. You also ensure that you take your patient's weight and height and surface area just for calculation of dosages of the drugs that are used. I've already talked about that. So the first line regimen that is currently used according to the 2018 guidelines is the first line for adults, or for adults, that is patients more than 15 years or patients who are more than 35 kgs. So these patients, your first line regimen will be tenofovir or abacavir, then taken with lamivudine and dolutegravir. That is the first line. And for patients who are in the women who are in the childbearing age, dolutegravir has not been cleared for the pregnancy, its safety in pregnancy. There is still the studies say that it could cause some neural tube defects, so it's not given to women of childbearing age, but it can be given to those who are menopause and it can also be given to children who are not yet in the childbearing age. But of note is that you can start it on women who are on family planning. uh, uh, the guidelines say that you can start it on women who are on family planning and they do not yet want to have a child at that point in time. So I didn't see the recommendations, or rather the guidelines on when to stop it and how far from pregnancy to stop the dolutegravir, if at all you stop it. So maybe Dr. Shamim will help us understand that if you start it on women who are on family planning, when exactly do you stop it for them to get pregnant? So on the second line now, once your first line have failed, or say the patient is not improving on your first line, so you'll want to do your second line regimen, which will be either zidovudine, lamivudine, and atazanavir, or tenofovir, lamivudine, and atazanavir. So the common side effects of the antiretroviral drugs are listed here. So the common ones, I have not exhausted the list. There are others that I didn't include here that you will go check. So abacavir will give you hypersensitivity reaction. So if you get a hypersensitivity reaction from abacavir, then you do not you do not give the drug again to the patient. Zidovudine might give you anemia, neutropenia, lactic acidosis, or lipoatrophy, and tenofovir will give you renal dysfunction. So efavirenz will give you CNS side effects and gynecomastia, and nevirapine is hepatotoxic, among the other side effects. So the general principles in managing the side effects of these drugs is that if there is history of a possible adverse reaction, you assess it clinically and in the lab if possible, then you evaluate the current medication. So you see if there is any drug interactions or any other medical conditions that would worsen the patient's situation. If a patient has a liver disease and you've given them a hepatotoxic drug, then that way it will bring out the side effects. So once you determine that there's an adverse effect of the event of the drug, if it's mild, you can continue the drug as you monitor, or you do symptomatic relief, just supportive management. If it's moderate, then you will continue the ARVs as long as they can take them, then you will change to a different regimen. So if it's severe, in this case, you will you will substitute the offending drug. You will substitute the offending drug without stopping the whole regimen. So if a patient was reacting to tenofovir, then you will substitute just the tenofovir and continue with the other drugs that they are on, and you will substitute the one that they're reacting to. So if it's a life-threatening reaction, then you will discontinue all drugs, stabilize the patient, then reintroduce a modified regimen. So on follow-up of these patients, we know that these patients come to pick their drugs. They should be followed up for adherence, and we should also ensure that these patients are improving with the medication. And if they're not, then you need to change their regimen. So on follow-up, you need, as I said, you need to do your viral loads every 6 months from the start of antiretroviral therapy. And remember, you also did a baseline. So with these subsequent follow-up tests, you will be looking at the improvement in terms of their viral load. It should be reducing, and you will repeat this viral load after every 6 months until the viral load is undetectable. And then now, after that, you will do the monitoring viral loads yearly. So other tests that you do to see if there's any side effects or the derangement, depending on where the drugs are being metabolized or excreted, or the side effects the drugs have. So you'll do CBCs, LFTs, and I forgot UECs every 3 months for the first 1 to 6 months. And then you will continue yearly as indicated. As the patient comes to you, you will see if they're having side effects, then you will do these tests. So when to change the treatment, we talked about first line and second line, and there's a possible third line. So when to change this treatment, if there's toxicity or intolerance to the current therapy, you here, when there's toxicity, you will change the drugs depending on what level they are. So if it's grade 3, as we said, you will change the offending agent. If it's grade 4, you will also change the offending agent, but you will stop the whole treatment, then reintroduce the modified one. Drug interactions, if the patient is gets or has an opportunistic infection on top of the HIV that they have, so you will be managing both of them at the same time. You need to ensure that these patients are these drugs are not drugs that are interacting. So for example, in HIV and TB, you might get a reaction interaction with rifampicin. So you want to give drugs that do not interact with rifampicin. So if they already were on a drug that will interact with rifampicin, then in that case, you need to change the drug first before you start the anti-TBs. If there is potential lack of adherence, if the patient cannot tolerate the drugs, they do not like their regimen, you give them a regimen that is good to them so that they can adhere to the drugs. And then if there is treatment failure, so some of the things that can give you a failure is poor adherence, inadequate drug levels. So if you give a lower dose, you will get treatment failure. If the patient is resistant to the drug, if there is inadequate potency of the drug interactions, and also impaired absorption. It could be due to chronic diarrhea, which is also a presentation of HIV. So before failure is determined, the patient should have received the regimen. Before you say it's ART failure, the patient should have received the regimen for at least 24 weeks. For you to say that now we have treatment failure here, the patient should have received the drug for at least 24 weeks. There should be optimal adherence to this drug, because adherence is a major factor in this drug failure. You should have treated any opportunistic infections that are there, and because the patient might be actually succumbing to the opportunistic infection while the ART treatment is just working fine. So you need to treat all opportunistic infections for you to say the treatment is failing. So treatment failure is determined in three ways. There is a clinical failure, immunological failure, and virological failure. So clinical failure, we say a patient has clinical failure when there's appearance or reappearance of WHO class 4 events after at least 24 weeks of ART and adherence. So the patient was adherent, and you've taken the regimen for 24 weeks, and the patient has now gone to stage 4 of the WHO classification. So this means that your patient has had a clinical failure, like the drugs they're taking are not improving their clinical state. And also immunological failure is defined by your CD4 count. So here, if there is a sustained CD4 count, a sustained decline in CD4 count, to below levels of pretreatment. Like you are treating the patient, and instead of them improving their CD4 count, their CD4 count keeps going down. And if there is a incomplete immunological response where CD4 count fails to rise by at least 50 cells during the first year of heart. Remember, the first one is within 24 weeks. So if there is sustained decline despite your management for like 24 weeks, then that qualifies to be immunological failure. Or you've given the drugs for like a year and the patient has failed to, has risen, their CD4 count has risen, yes, but it has failed to at least to rise by at least 50 cells. So that means there is immunological failure. And if the CD4 count drops by more than 50% at the peak of the at the peak achieved at heart, like here, this just means that as the patient is taking the ART management, the CD4 count drops by more than 50%, regardless of the timing. Like it doesn't have to be 24 weeks. If it has dropped by 50% and the patient is on heart treatment and they are adherent, then that means there is immunological failure. So in the virological failure, when there is incomplete viral suppression or viral load remains high of more than 1,000 copies per mil in a patient on ART for at least 24 weeks. And this test, the viral load test, is based on 2 consecutive measurements that are 3 months apart. I hope we've gotten the key points there. So it's a viral suppression or, sorry, incomplete suppression, or the viral load remains high or even higher than it was, and the patient has been on management for 24 weeks, and the viral load has been taken 2 consecutive measurements that are 3 months apart. And you have to confirm that there was adherence to the drugs. Okay, so once we confirm that there is now failure, treatment failure, we need to change the drugs to the second line. And in this, you switch the drugs to the second line, but you don't stop the drugs you are giving currently. As you switch, there should be no, you don't stop and then start like after 2 days. As you're switching, you just switch the drugs immediately. So you give them their regimen. For example, if a patient came to you today and you've confirmed that there is virological or immunological failure, then in this case, you switch their drugs. You let them finish their drugs for the day, and then you switch the drugs the following day. There shouldn't be any break between the regimen. So there is the prophylaxis that we give for patients who are at high risk or patients who have been exposed, accidentally exposed to these viruses. So in so for post-exposure prophylaxis, you give them the regimen is dolutegravir, tenofovir, lamivudine, or atazanavir, tenofovir, and lamivudine in women who are in childbearing age. As we said, women who are in the childbearing age do not get dolutegravir. So this pre-exposure prophylaxis is given as soon as possible. That is within 72 hours of the high-risk exposure, and it's taken for 28 days. Then after the 28 days, the patient is tested for HIV. If it's negative, then we will stop the regimen. If it's positive, then we will have to start them on now the ART management. So on the other hand, for pre-exposure now, pre-exposure prophylaxis, the regimen has 2 drugs. So it has tenofovir and Emtris, okay, that drug. So it's offered to people who are HIV negative. Remember, you have to do a HIV test for these patients, for these individuals, before you give them the pre-exposure prophylaxis. So it's for individuals who have whose initial test is negative, but they are at high risk. Either they are sexual workers, or they are people who are frequently exposed to the HIV virus. So that way, or they are IV drug users. Those people, you give them pre-exposure prophylaxis of these drugs. But then I didn't really see the guidelines on when or after how long, after starting the drug, how long it takes for them to start or to continue with their a high risk behavior. So I don't know if Dr. Shamim can also clear that for us. So other prophylaxis that you give is for opportunistic infections. So for pneumocystis and toxoplasmosis, the patients are usually on Septrin that they take together with their ART regimen, and they take it for life. Like the prophylaxis is for life. As they take this ART for life, they also take Septrin with it. So the Septrin for adults is in the double strength. They will take only 1 tablet daily, but in the single strength tablets, they will take 2 tablets per day. Isoniazid prophylaxis is prophylaxis for tuberculosis. So in these prophylaxis, we give isoniazid for 6 months. We give isoniazid for 6 months, and we give it to all patients who are 1 year and above. All patients who are 1 year and above, and they are patients living with HIV. So you've already done your test and it's positive, then they are 1 year and above, you give it to all these patients, and it's given only, the prophylaxis is given only once in the lifetime. So you will not give it another time so this prophylaxis. So you give it once in a lifetime, and you give it for 6 months. And you remember, as you give isoniazid, you give also with vitamin 6. Yes. So now we are going to the opportunistic infections. We are going to tackle TB, iris, and cryptococcus, among others. So in iris, iris is an inflammation. It's basically when your body is now getting better, your CD4 count is getting better with introduction of ARTs. Now the infections that were latent are now recognized by this immune response. So your immune response is getting better, and it's getting to recognize diseases that were there but were not being recognized by these immune cells that were immunosuppressed. So therefore, you get reappearance or development of presentations, symptomatic presentation of these diseases. So it appears when you have reinitiation or initiation of ARVs after stopping, or you change to a more active ARV. For example, in treatment failure, you'll be changing to a more active ARV. So that way, then you trigger these other infections that were latent. So the risk factors for these are low CD4 counts, unrecognized opportunistic infections, pre-existing opportunistic infections, and early ART initiation. So the pathogenesis is, as I've said, your immune reaction is improving, so it's being you are restoring your CD4 count, and therefore your immunity is getting to recognize the pathogens that were undetected at before the initiation of the ARTs. On the evaluation, you will just you will see specific symptoms for specific diseases. So if it's TB, you'll see a cough or difficulty in breathing, weight loss. You will see drenching night sweats. That way, it's specific for different diseases. Once you recognize that, then you will if there is an opportunistic infections that was ongoing and it might worsen with the initiation of ARTs. So you have to consider all these factors, and you have it in mind, because when you start these ARTs, your patient may get worse before they get better. So the treatment for this is just to continue with your ART. You do not stop it. Like if it's mild, you will just give some NSAID and continue with your ART. If it's severe iris, then you will give prednisolone, and the duration of the drug depends on the response of the patient. But of note is that you continue the ARTs unless it's a life-threatening condition like encephalitis, if there's rising ICP, or there is development of blindness. This means that this is affecting the CNS. So you have to discontinue this drug, and then you will again reinitiate the drugs, but now a different regimen. For tuberculosis, we know it's caused by MTB, which is a strict aerobe. So it's the commonest opportunistic infection, and it leads to mortality in HIV to up to 50%. Prophylaxis, as I said, is isoniazid you give with vitamin 6 for 6 months. The primary infection in HIV is usually the apices. So when you do a patient presents to you, even if they're in their symptomatic phase, they are not they are still in WHO class 1 where they are asymptomatic. You can have a high suspicious index when you see TB that is the apices. So in HIV, they can have pulmonary TB, they can have pleural effusion, they can have TB adenitis, they can have miliary TB, or even TB peritonitis. So here, it just means that the TB can be worse in a patient who is immunocompromised. So you will see them presenting with features of a cough, maybe difficulty in breathing, weight loss, and drenching night sweats. But also they will have these particular symptoms depending on where the TB is. The diagnosis, the gold standard is GeneXpert. But you can do these other tests like a chest x-ray to just see how the lungs are affected. So the treatment of TB is you use anti-TBs. So you will use the full regimen for anti-TBs, isoniazid. So you'll do it's called the intensive phase for 2 months, and then you'll do the maintenance phase for 4 months if it's not TB meningitis. But if it's TB meningitis or TB bone, then you will do the maintenance for 8 months. Yes, sorry, for 8 months. So in the initiation of anti-TBs, if a patient was not yet on antiretroviral therapy, you start anti-TBs immediately. Then you can initiate your ARTs as soon as they are stable on their anti-TBs and they can tolerate their anti-TBs, preferably within 2 weeks. But if they're having TB meningitis, then you can delay your ARTs for about 8 weeks, then you can start your ART. But for patients who are already on ART, you start your anti-TBs immediately. And you make sure that you readjust your ART regimen based on the interactions or predicted interactions with the anti-TBs. So for PCP, it's caused by pneumocystis jirovecii. The infection might be there even from childhood, but when now you are immunosuppressed with HIV, then it becomes symptomatic. So it's apparent with a CD4. It appears if your CD4 count goes to less than 100 cells per microliter, and the symptoms are shortness of breath, dry cough, fever, and chest pain, among others. You might present with tachycardia, tachypnea, or cyanosis. So when you do a your chest exam, it might be normal or it might have non-specific rails. So diagnosis is on your chest X-ray, you will see diffuse infiltration of the lungs. You will have hypoxemia on your BGAs. You will have decreased partial pressure of oxygen, and then you'll have raised LDH. So you can diagnose it with either a PCR or lung biopsy. Treatment, the first line is high dose Septrin for 21 days. These HIV patients are usually given Septrin prophylaxis for this, but when now they develop active disease, then you give them high dose ceftriaxone. Sorry, not ceftriaxone, high dose Septrin, which was, okay, I'm not sure of the dose. You'll just go and check the dose of the high dose Septrin. Second line for this is the IV pentamidine, 3 milligrams per kg per day, or you can use clindamycin plus primaquine. Mild to moderate disease. So this is for severe symptoms, but for mild to moderate disease, you can just continue, or you can just give the oral cotrimoxazole. We've already talked about the prophylaxis. For toxoplasmosis, it's a CNS disease. It presents with headache, fever, confusion, seizures, or focal deficits. It presents also with a CD4 count when it gets to less than 200 cells per microliter. The treatment for it is it has an induction phase and a maintenance phase. So in your induction phase, you'll use pyrimethamine, 200 milligrams per oral, or this is just Septrin. Sorry, it's there's a pyrimethamine and sulfadiazine is in a combination. You get Fancida. So when these two drugs are combined, you will give Fancida. That is the induction phase. An alternative for that medication is you give the high dose Septrin for 6 weeks. Remember, we were giving prophylaxis Septrin, which is low dose. So now when you have active disease, you can opt to give high dose Septrin, but the first line is Fancida. Then on maintenance, maintenance is for a lifetime. So this is when you give Fancida again, or you can give Septrin. For Cryptococcus, sorry. For Cryptococcus neoformans, it's a fungus. It's yeast-like, so it's you get it from the soil, and it causes subacute meningitis or meningoencephalitis. So patients will present with fever, headaches, neck stiffness, or memory loss. They can have CNS palsies or impaired consciousness. So for the diagnosis, you will do an LP. So the CSF opening pressures will be raised, markedly raised to above 200 millimeters of water. So for the CSF, you will do serum CRAG, which in 95% of cases is positive. So CSF CRAG, which is in 95% of cases is usually positive. Then you can also do Indian ink, which is in 60 to 80% of cases is positive. And you can also do blood cultures for disseminated disease. So once you diagnose cryptococcal meningitis, then the treatment has both an induction and maintenance phase. So on induction, you give amphotericin B plus fluconazole for 12 weeks. For consolidation, you'll give fluconazole 400 milligrams for 8 weeks, and then maintenance, you will give 200 milligrams of fluconazole per day. You will discontinue these medications if the patient's CD4 count is more than 200 cells per microliter. You can also do therapeutic lumbar puncture taps if the patient is presenting with very raised intracranial pressures. There are oral lesions that you get. So there is candidiasis, which you treat with fluconazole. Aphthous ulcer, which you just do antiseptic techniques, and then you treat with prednisolone. Kaposi sarcoma, which are purple lesions within the buccal mucosa. So you'll just continue with your ART treatment, and they will resolve. So for esophagitis, you will get candidiasis, which you treat with fluconazole. If you get herpes simplex, you will treat with acyclovir. CMV, you'll treat with Valgans, that drug. And then the aphthous virus or aphthous ulcers, we said you'll treat with prednisolone. So for diarrhea now, as we said, in stage 3 and stage 4, there is diarrhea as a presentation of HIV. So it could be acute or chronic diarrhea. I've listed the causative agents of both acute and chronic diarrhea. In its treatment, it depends on the causative agent and the drugs they are sensitive to, which I've also listed there. Thank you. So I'll hand over to Dr. Shamim or any other person who has a question before we hand the presentation over to Dr. Shamim.
Okay, I don't see any questions. Can you hear me? Flavian, you can hear me?
Yes, I can hear you.
Okay. So I have quite a few comments to make. So I think you'll just update your epidemiology of HIV. We have latest data from UNAIDS in 2020, and we also have some new data from Kenya as well. I think the KenFIA survey. What I'll do is, KenFIA survey. What I'll do is I'll send it to Flavian, who can then send it to everyone else. So apart from that, I wish there was, I wish the fourth year part would have gone further into the immunopathogenesis of HIV, because that is important. So please, all of you, we still have time during this rotation. We need to look at that. How does, what cells does HIV infect? What happens? How do you get things like, you'll hear things about sanctuary sites, you'll hear about elite controllers. So it's all about the immunopathogenesis. It's a bit long, but please take time to look at it, because we didn't look at it during this session. And then the other thing on the previous presentation was the replication. We passed through it very quickly. It's also very, very important in HIV, because all the drugs that we've mentioned, we actually have mentioned that we use for treatment. Once you understand the replication, you can understand how those drugs affect HIV. Like if you look at the non-nucleoside reverse transcriptase inhibitor, when you look at protease inhibitors, when you look at integrase inhibitors. So all of them, when you look at the replication cycle of HIV, it will tell you exactly where the drug will act. So it will make it easy not only for you to remember the replication cycle, but also to know how the drugs work. So please spend some time to look at that. The other thing I wanted to mention about the replication of HIV is that it replicates a lot. Actually, it has a very high turnover. On a single day, almost 10 to the power 10 virus particles are produced in a patient who's not on ART treatment. So it can tell you of how much the replication goes through the human body at that time. So it's really important for you to understand that. I'll just go through the notes I was making. So testing, especially in the previous presentation when they talked about the acute HIV, it is important. I know we went just through testing, and Flavian talked about counseling, what you need to do. It's also important to know which test can be done when. She mentioned something about the window period. We need to understand which period this is. Apart from the window period, there's also a period called the eclipse period. This is a point where no HIV test, none can pick up the HIV diagnosis. So it's usually the initial stage where no diagnostic test is actually capable of detecting HIV. And then after that, of course, we have the first test we can do is the HIV RNA, which will be first positive. Then you have your P24 antigen, which will be positive. Then you can have your antibodies, and finally you can have your Western blot. So it's important for us to know which stages and what test can be done and what can be missed. So I'll send out a table that will simplify this. Flavian will also send out to the group so that it makes it easier for you to understand how testing is done. We use a lot of antibody tests, but that is usually can miss acute HIV. And then, so it's important when we talk about treatment of HIV in our setting, we have the National AIDS NASCOP guidelines that we have to look at, because that is what guides our HIV treatment for us. And it's mostly guided by the WHO guidelines. So we have the latest guidelines that we have. I know there might be a new guideline coming out this year, but the latest one we have is from 2018, and it will actually simplify your life. about what we need to do in HIV. I wonder if someone can make me a host so that I can share with you, or you can make me a host later, and I'll share with you later after we discuss. So there are a few pages you have to look. It's a very big document. You don't have to go through everything, but it has a summary section where you can just look at it, and it can tell you what do I need to do in the history, which tests am I supposed to do, which test am I doing for follow-up of these patients. So please look at the NASCOP guidelines so that you know what you need to do for our patients and which therapies we use for our patients. So based on the NASCOP guidelines, we do not do a baseline viral load in Kenya. We also do not do a baseline genotype. There are a few tests that Flavia and Easton has lied, like the CRAG, which we usually do reflexly, or the lab does in patients who have CD4 less than 100. Most of the time you might not have to request for it. If it's less than 100, the lab goes straight ahead to do a CRAG for you. You have to do a pregnancy test, a urinalysis, VDRL. You have to do your hepatitis B, C tests as well. So the guideline will make it easy for you to know which tests are supposed to be done. So the goal of your antiretroviral therapy is viral suppression. And that is below the limit of detection. So some viral load machines can measure viral loads, like the lower limit of detection could be 20 or 40. So basically what you do for the goal for treatment of these patients is for viral suppression. So it was, Flavian rightly said that our first line therapy in patients who are above 15 years of age is tenofovir, lamivudine, and dolutegravir. There are also other regimens that are recommended for children and those who are less than 35 kilograms of weight. So she mentioned about dolutegravir and the issue about pregnant women and its association, or rather association with neural tube defect. So dolutegravir, why was it chosen as the first line in most countries actually in the world, is that because dolutegravir is a very highly efficacious drug. It drops the viral load so quickly. Secondly, in the world, there were increasing rates of transmitted drug resistance, especially from NNRTI. So having used NNRTIs for long, many areas of the world, like East Africa, the US, Europe, there was a lot of increase in transmitted drug resistance. In some areas, it was up to even 15 to 20%. So it was important to come up with a drug that is highly efficacious and people do not have resistance to it. Additionally, dolutegravir has fewer side effects compared to efavirenz, and it has what we call a high genetic barrier to resistance. What does it mean? So an ARV drug that has high genetic barrier to resistance need multiple mutations for the HIV virus to get resistant to it. Unlike drugs like efavirenz and nevirapine, which only need one mutation for the HIV virus drug to be resistant to it. Remember, as we mentioned before, the high turnover of the ART of the viral replication 10 to the power 10. In addition to that, that is always like, it's a high turnover, but it's also an error-prone process. So out of those 10 to power 10, there are a lot of mutations that occur in those viruses that are being produced, and getting resistance can be very easy if you have a drug pressure with a replicating virus. So which the DTG was chosen because of high genetic barrier to resistance as well, and also its cost was also not so bad. So after DTG was rolled out, they did a study in Botswana. It's called the SEPAMO trial. It's not a trial actually, it's a study. It's an observational study where they looked at patients who were on efavirenz and patients who were on DTG, and they noted that patients who were on DTG, the rate of neural tube defects was high, especially in those patients who are using DTG during pre-conception, like during the first 8 weeks of conception. So that is it was in 2016. and they actually put out a notice, and the FDA as well, that we should not use this drug in women who are of childbearing age, and if we are putting them on this drug, they need to be on contraception. However, the SEPAMO trial continued from 2016, 2017, 2018, 2019. The latest data that we have from 2020 from SEPAMO trial, it shows that the rate of neural tube defects in patients who are on DTG and those who get pregnant is very low. It's actually, I think it went down to 0.0 something percent. So WHO came up with a new guideline, and I think the Kenya guidelines also put out an circular about it, that we can use it in women, but it has to be a shared decision making with the woman, that she needs to be informed that this drug can do this, can have a risk, but you can still use it, even in women who don't use contraception. So it's really shared decision making. You don't say that we don't use DTG in women. So it's just that you discuss with the patient so that they are aware that this drug has a risk, a slight risk of neural tube defects, but you will still use it in women with a childbearing age. So the other thing that is really important to know is the side effects of antiretrovirals. I know we did not go through that, but it's important for you to know. Drugs like AZT can cause anemia, can cause lipodystrophy. You have NNRTIs, efavirenz, and nevirapine. I think Flavian mentioned a few of those. With nevirapine is hypersensitivity, as well as hepatotoxicity. And then efavirenz can also cause a lot of neuropsychiatric side effects. With patients can complain of very, very vivid dreams. They can also complain of dizziness, and some of them can have suicidal ideation. So those are a few things that you need to know so that you can ask about them. With the PIs, mainly it's usually diarrhea, GI side effects with diarrhea, nausea, vomiting. And then with integrase inhibitors like DTG as well, it's usually a few of the neuropsychiatric side effects. Some patient complains of headache, other patients complain of insomnia, that they cannot sleep at night. So you need to know at least a few of those side effects of the ARTs. And then you can still hear me, I guess. I hope I'm not talking to myself.
We can
Flavian,
hear you.
yes, okay. So the other important thing that Flavian touched about was substitution of antiretrovirals. So it's usually an important thing when you're substituting antiretrovirals. If a patient does not have like a grade 4 side effects like acute liver failure, or they are having a really bad drug reaction, it's really an important decision that you're making, especially a patient who has been on ART for long, and probably they might have side effects to it, or you might have a drug-drug interaction. Let's say you want to use rifampicin or TB treatment on a patient who's on a protease inhibitor. So it's really, really important, if this patient has been on ART, for you to check your viral load. Why is it important? Because we know we use multiple drugs. Let's say if a patient is on TDF3-TC and atazanavir and has been on it for long, now they have TB, you have to treat their TB. And you don't have another drug apart from rifampicin. So it's really important for you to check their previous viral loads, because there's an issue about, let's say, a patient who's not virally suppressed, their virus is, they're failing a first-line regimen or failing a second-line regimen, and then you say, oh, I have to treat TB, let me just change atazanavir to dolutegravir, or I change from nevirapine to dolutegravir, and this patient has very high viral load. That is risky because you're changing only one drug, and that is called a single drug substitution in a failing regimen. Imagine if that regimen is failing, then you're only putting one drug in this patient that is new. And that means the patient will be on monotherapy, and that means that that patient can get resistant to that drug very quickly. So it's important for those patients who've been on treatment for long, when you want to change their ART, please look to see if this patient has had CD4 viral load before, and what their viral load is, and see whether if their viral load is suppressed then it's easier to change. But if it's not suppressed, then you have to think about it and think that I need to avoid, is this patient failing? I cannot only change one drug because this patient will be on monotherapy. So the monitoring of viral loads, it's important to also look at our NASCOP guidelines and how we monitor. Usually it's 6 months after treatment and then annually if the patient is suppressed. What is also important for me to mention here is drug-drug interactions with antiretrovirals. You will see this a lot in the wards. So the first one I want to mention is nevirapine, but we don't use it a lot these days. Main interaction with those was anti-TBs and other drugs, but I'll talk a little bit about DTG and drug-drug interactions because it is important and because many of our first-line patients are now on DTG. So DTG interacts with metformin. So for those patients who are diabetic and also are being started on DTG, please make the maximum dose they can have of metformin is 1 gram per day, 1 gram in a day, because DTG increases metformin levels in blood. There's also interaction with anticonvulsants, carbamazepine, phenytoin. So be very look out for that, especially for 6th years who are going to be interns in a few.
Doc, we can't hear you. I don't know if you can hear me.
Hi, sorry guys, I was kicked out. My internet went off. Can you hear me now?
Yes.
Okay, so the others. So remember DTG with metformin, DTG with anticonvulsants, DTG with rifampicin. Now I wanted to mention DTG with antacids or any drug that contains that has metals with it, calcium, magnesium. So a lot of those antacids, they reduce DTG absorption. So please, if you have to use antacids in a patient who's using DTG, please time them like apart, maybe 3 to 4 hours before, 3 to 4 hours after. So you have to ask the patient when they're taking their DTG so that you do not affect the absorption of DTG and actually have lower levels of DTG in blood. The other thing I want to mention is atazanavir, which is a PI. With atazanavir, please be very careful about PPIs, because if you reduce the gastric pH, you reduce absorption of atazanavir. So be very careful about that and also talk to the patients about it. The other thing, of course, with protease inhibitors, as we've mentioned before, is rifampicin. If you have to start a patient on protease on PI-based ART on TB treatment, so you either have to, rifampicin does the same thing to PIs as DTG, it reduces the levels. So you either have to increase the doses or double dose your PIs, especially lopinavir, or you have to use rifabutin. So you have to be careful about that. There's an app that sometimes I use mostly, especially in patients with HIV. It's an app that looks at only drug-drug interactions between antiretrovirals and other drugs. It's called the iChat. You can download it from Google Play. It's free, the Play Store. And you can just have it in your phone when you have to take care of these patients. So the other thing Flavian mentioned was the immune reconstitution inflammatory syndrome. Basically, it is an exaggerated inflammatory reaction to a microorganism once you have recovery of the immune system in these patients. So you have two types. You can have a paradoxical, which is worsening of an already of a known infection. Like let's say you're treating TB and you started the patient on ART and they worsen, or it can be an unmasking iris. So you have two types, which is a paradoxical iris, which is worsening, or unmasking, which is appearance of a new OI after starting ART. So those are the two types of iris that you need to be aware of. So on the ART failure, we mainly don't use virological, mainly don't use clinical and immunological failure these days. We use virological failure, we do our viral load so that we can detect virological failure early. It's important because using viral load identifies patients who are failing ART earlier than like we would use like with the clinical or immunological failure with your CD4s. So Flavian asked a question about patients who are on PrEP. So remember that with PrEP, there are two things you need to know with PrEP and PEP. So with PrEP, it's given to patients who are at high risk of getting substantial risk of acquiring HIV infection, and then PEP is given to people who have already been exposed to HIV. So for PrEP, which is we use tenofovir, TDF, and emtricitabine, and then the indications are there in the NASCOP guidelines. Once I send it to you, I'll kind of send the pages so that you guys don't have to look at almost 300 pages of the NASCOP guidelines. And it's given to patients who, let's say, a discordant couple or a couple whose partner has just been diagnosed on ART with HIV, they're not on ART, their viral load is still high, or those patients whose partners have HIV and the viral load is still detectable. So those patients can be given PrEP. You can also give PrEP to a patient whose partner, they have no, they're of unknown status, or they are at high risk of infection. Sexual workers can also be given. A patient who, of course, are injection drug use where they share needles or syringes, are also serodiscordant or discordant couples who are trying to conceive. How long do you use PrEP? So it depends until your risk is reduced. So when you look at the NASCOP guidelines, there's also indications for starting and indications for stopping. So if your risk is reduced, your partner is suppressed, then what you can do is you can stop PrEP. Remember, there's the what is it? I think you guys have heard of U is equals to U, which means undetectable equals to untransmittable. So if you have undetectable HIV, your risk of transmitting it to your partner is very low. So for those patients who are whose partners are not are suppressed, they can stop PrEP. But if there's still high risk, they need to continue with PrEP. The other thing is, I think for TB, that was very brief. I think in your timetable, there's a class for TB. But just remember the drug-drug interactions between anti-TBs and ART. So I'll touch briefly on PCP. PCP, of course, is a opportunistic infection. The dose for high-dose Septrin, and Flavian rightly said that You can have symptoms are usually subacute. Patients can come with a dry cough, sweats, weight loss, exertional dyspnea. And your X-ray can either be normal or you can have bilateral infiltrates. One very common and not very common, one very bad complication of PCP is that you can have pneumothorax. So don't forget about that. So you can either have a normal chest X-ray, you can have bilateral infiltrates, or you can have also a pneumothorax. So treatment-wise, high dose steroid, high dose septrin. The dose for high dose septrin is, so remember your septrin is trimethoprim sulfamethoxazole. Please don't confuse it with Fancida, which is pyrimethamine sulfadoxine. So septrin is trimethoprim sulfamethoxazole, and high dose septrin is, we dose the high dose septrin using the trimethoprim component. So you dose it by 15 to 20 milligrams per kg of the trimethoprim component. So when you look at trimethoprim sulfamethoxazole is usually easy. It's usually 480 milligrams, the single dose. 80 milligrams trimethoprim, 400 milligrams sulfamethoxazole. So using that, then you can calculate how many tablets a patient needs to use. Additionally, in patients who have hypoxia, those patients with SpO2 is less than 90 or their partial pressure of oxygen is less than 70, you need to add steroids in these patients. So the dosage of steroids is usually prednisone 40 milligrams twice a day for 5 days, 40 milligrams OD for 5 days, and 20 milligrams OD for 11 days. That's a total of 21 days of treatment for PCP. The other regimens, of course, you can use clindamycin primaquine in patients, pentamidine in patients who are have sulfur, cannot tolerate sulfur or allergies. So the other thing you looked at is toxoplasmosis. Toxoplasmosis is one of those important things in opportunities infection in HIV. You need to know the CT findings of patients with toxoplasmosis. So the CT findings, as I think some of you have heard it in the ward rounds, is that these patients usually have multiple ring enhancing lesions and with surrounding edema. Hi, sorry guys, my internet is absolutely not working today. So we talked about toxoplasmosis. It's important to differentiate TB, tuberculoma. You can also have brain abscess, and also progressive multifocal leukoencephalopathy, which is PML. And then so you can use Fancida, as Flavian mentioned, but what we use currently here is high dose septrin. It's usually 19-20 milligrams BD, PO, of high dose septrin. You really need to know cryptococcal meningitis. So Flavian has gone through that. Patients can can come in with complaints of headache, confusion, acute confusion. And then the lab works, you need to do, of course, your LP. And here you look at your biochemistry. Your protein might be high or not high. It can be normal. Your sugar can be low or normal. Your cell counts can have lymphocytes, but you don't do a lot of cell counts here. India Inc is usually positive, and your CSF CRAG can also be positive. But remember that in those patients who have very high burdens of cryptococcal meningitis, they can have negative CRAG just because of a phenomenon that we call is a prozone phenomenon. But they still have cryptococcal meningitis. Treatment is very important. Knowing that you have the induction and the maintenance, the induction, consolidation, and the maintenance phase. The induction, you use amphotericin B and fluconazole. Flavian, you need to correct your slide. Amphotericin B dosage is 0.7 to 1 milligram per kg, and fluconazole is 1200 milligrams once a day for the induction phase, then 800 milligrams for the consolidation phase, and then 200 for 200 milligrams for your maintenance phase. There are I think a few other conditions that you need to look up, which I think I've mentioned: primary CNS lymphoma. You also need to look at progressive multifocal leukoencephalopathy due to the JC virus. You also need to look at your chronic diarrheas causes, which include Cryptosporidium, Isospora, and Microspora. You don't need to know a lot about it, but just to know what they are and when they happen. And then, yeah, I think that's it. So you look at, apart from the Cryptosporidium, Isospora, Microspora, you also need to know about CMV and MAC. And also, please, I think you'll have a class about it, is Kaposi sarcoma. Do not miss that. And then, yeah, I think that's it. I saw there were a few questions, but I lost them. Oh, they're still there. So I'll look through the chat. So the question is, when a patient has both TB and HIV co-infection, is ART started after 2 weeks or after 8 weeks? So Tabitha, this is mainly based on a study. I think it was the SAPIT trial, which they looked at that patients with who are HIV positive and their CD4 is less than 50. Those patients, you need to start ART after 2 weeks. And those patients whose CD4 are more than that, you can start them after 8 weeks. But commonly, practice here has been to start patients after 2 weeks of treatment. Basically, that was just because they saw a lot of iris in patients. So it's based on a trial, a SAPIT trial. If CD4 is less than 50, start ART after 2 weeks. If not, you can start at 8 weeks or after 8 weeks, but the practice is that you can start most patients are started after 2 weeks. Induction phase, Kamuri says, induction phase in cryptococcal meningitis, is it for 12 weeks or 2 weeks? Kamuri, no, it's not 12 weeks, because remember, the side effects of amphotericin are very bad. So you need to know also, I forgot to mention that, you need to know about the side effects of amphotericin, because you see it frequently in the wards, and you'll be asked, of course, in your exam as well. So we don't do it for 12 weeks, it is 2 weeks of induction phase of amphotericin plus fluconazole. So amphotericin 0.7 to 1 milligram per kg plus fluconazole 1200 for 2 weeks, and then fluconazole only for 800 for 8 weeks, and then fluconazole 200 after that. So Tabitha again asks, in treatment failure, do we manage the patient with second line treatment option, and how do we manage patients with liver failure plus TB, HIV co-infection? So I'll start with the first one, which is treatment failure. So we have first line, which we said is TDF3TC DTG or a combination of that. And then your second line is maybe, let's say, AZT3TC, which is a PI-based regimen. So once you fail your second line, So in a patient who's failing second line, remember what Flavian said, that a patient who is on any of these lines, but let's focus on second line because Tabitha's question is what in a patient who's failing second line. So in a patient who's failing second line, they're on second line, their viral load is above 1,000. Then you put this, you have enhanced adherence counseling sessions with this patient to make sure that they are adhering to their ART. And after 3 months, you test your viral load and it is still above 1,000. So in these patients, what you do, you need to do a genotype. So a genotype basically just looked, it's like MCS, culture and sensitivity for antibacterials, where you look at what mutation, if the ART HIV virus has a mutation against the antiretrovirals. So you do a genotype. In other countries, in high income countries like the US, Europe, they usually do their genotypes when they start ART to see if this patient has transmitted drug mutations or resistance. But for us, we don't do it when we are starting ART. We do it when the patient is failing their second line antiretroviral regimen, especially a PI-based ART. So if this patient is on tazanavir or they're on lopinavir and they're failing their regimen, we have a way that we do this. We request for a genotype through NASCOP, and once it's approved by NASCOP that you have to do a genotype, it is done. And then you look at the genotype result. I think I have some in my Nini. In my computer, I'll share it with you when I'm sharing I think there was something I was to show you the Kenya ARV guidelines. I'll show you what a genotype looks like. So you use the genotype to guide you to see if this patient is, whether they've developed resistance to antiretrovirals. So if they've developed resistance to antiretrovirals, especially your protease-based inhibitors, protease inhibitors like atazanavir and lamivudine, you go to third line antiretroviral therapy. So your third line your third line drugs will depend on what drugs are resistant, what drugs the HIV of that patient is resistant to, and then you choose the drugs based on your genotype results, and that's when you use your third line. Unfortunately, after third line, we don't have very many options, so we usually try to get our patients to adhere to their third line regimens and follow them up very closely. The other question is, how do we manage patients with liver failure plus TB and HIV co-infection? So the question here is, Tabitha, is the liver failure due to drugs? Yeah, because if sometimes you start patients on TB drugs or maybe HIV drugs, they can get drug-induced liver injury. If it's not due to that, these are patients, if they have liver failure now, they have TB, they are a very high risk of getting drug-induced liver injury. So you can start them on treatment, but be on the lookout for so your liver failure, it's really hard to know whether you meant acute liver failure or chronic liver failure. So I'm talking about patients who have probably chronic issues, so you have to watch them closely. But if it's drug-induced liver failure due to TB drugs, then you have to do a holding regimen. And if it's due to HIV drugs, then you have to know which drug it is, and you might have to change that. So Tabitha, concerning treatment failure, do we need all three parameters to diagnose failure, or even one is? No. So I think I've answered this question, that we use viral load and we use virological failure to diagnose treatment failure. As I've said before, immunological and clinical failure drugs. So by the time a patient, by the time you say, oh, we are on a clinical failure, it will have been so long that patient has failed, or so long by the time their CD4 falls. So we use viral load to catch treatment failure earlier. So John asks, in our setup now that we don't do baseline viral loads, when do we do viral loads for follow-up? So you do your viral load. So if it's a patient who has been on ART and then you do a drug substitution. Let's say they were on efavirenz, and now the guidelines say that patients on first line need to be on dolutegravir. So they were on TDF3TC efavirenz, and now you're changing to TDF3TC dolutegravir. So those patients, you have to do your viral load at least after 3 months. So if it's a new patient, you just start your ART, and then you check your viral load after 6 months, then after if they are suppressed, after 1 year. If it's an adolescent, then you have to check, and their children, you have to check your viral load every 6 months. I hope I've answered that question, John. Now I wanted to share my screen. I just want to share my screen, but to hide patient information. So let me try to do that so that I can show you the genotypes and how they look like in patients. I hope you don't have another class after this.
No class, no class.
Okay, so let me just share my screen so that I can show you what a genotype looks like. So this is what a genotype looks like. So I don't want to go until the patient name. So there's a so what basically it shows you, the genotype shows you the subtype of HIV, and this is we did in a patient who was on second line ART and they were failing. And then it looks like when they look at the HIV virus of the patient and which drug is resistant to it, you can see this patient had high level resistance. If the first thing we look at is you have different type of mutations, and each mutation affects a certain drug. So remember, I think we can go back a little bit. NRTIs, NNRTIs usually have a little low barrier to resistance. PIs have higher barrier, and integrase inhibitors have higher barrier to resistance. So if you look at atazanavir, you have high level resistance. So all these are protease inhibitors. So we use atazanavir, high level resistance. Lopinavir has high level resistance. So, and then we go down and we look at NRTIs. You can see that this patient has resistance to abacavir, has resistance to low-level resistance to zidovudine, but tenofovir is susceptible, has very high-level resistance to lamivudine. And then when you go to NRTIs, the patient is fully susceptible to efavirenz, etravirine, doravirine, nevirapine, all those drugs are susceptible. So this is how we do drug resistance testing in patients who are failing second line. So one important thing that I want to mention, you might come across this, it's in your clinical life. Maybe not, no one will ask you this in exams, but just to know that patients who, one thing that is important, is interesting with the HIV virus, it's that like animals in the forest who have survival for the fittest. Yeah, so the virus always wants that the most fit virus survives. Okay, so the wild so let's say a patient has been on PIs, and then or first line therapy, they failed their first line therapy, then they went to their second line therapy. So let's say they used their first line therapy from 2006 to 2008, then they failed, and from 2008 to now they are on second line therapy, but they are failing their second line therapy. And at this point, we are doing our genotype. So probably this patient, you can suspect that this patient was on an efavirenz-based first line, and they are now on a second line. So the thing about HIV virus is once you stop using a drug, or once you stop using an ART, it reverts to the wild type virus. And when you do your genotype at that point, the wild type virus does not have any resistance to any drug. So in patients who have stopped drugs for a long time, or patients, and that's why we focus on adherence in patients with HIV, so that they can achieve viral suppression, but also patients whom we are going to do genotypes, you have to make sure that they are on their ART. If they are not on their ART, the virus, the wild type virus starts replicating and the drug resistant virus disappears. So like this patient who was on efavirenz, let's say years ago, right now you look at their genotype, they are fully susceptible. It's just because they have something we call an archived resistance. So if you use this genotype and say this patient is fully susceptible to efavirenz, the efavirenz virus, the efavirenz resistant virus will start replicating because it's the survival for the fittest. So when you're choosing third line drugs, it's not only important to know your genotype, it's also important to know which drugs the patient used a long time ago and they've stopped, because they could have archived resistance, and if you restart those drugs, then they'll become resistant to it. Okay, so let me share another screen. So let me just show you the ART guidelines so that you can see how it is. You don't have to look through the whole document. It's quite long. You might have to spend a few months reading it. So I'll just show you a few areas that you can look up. So let me share my screen again. Oh, I can't see it. So I hope you can see my screen. So when you look at the NASCOP guidelines, this is the NASCOP guidelines, and you can look at guidelines, initial clinical evaluation of people living with HIV. So you can see how easy it is. You can see, they tell you what history to take, and then they have comments. What are you going to ask? Psychosocial history, what are you going to ask? Sexual and reproductive history, what are you going to ask? Physical examination, what are you supposed to do? General, systemic, summary. And then it tells you which test you need to do. Initial laboratory, these are the tests that you're supposed to do. And then after that, it also tells you which test you need to follow. So you see that it's very easy. It just tells you like what you're supposed to do. So which baseline labs should I do with people living with HIV? It tells you which patients we do viral load and which one we don't do viral load. Serum CRAG. So you can see that we don't recommend. Drug resistance testing is the same thing as I was talking about genotype. So drug resistance testing is a genotype. So it's not currently recommended as a baseline investigation. And then you need to do your HP, you need to do your pregnancy status. So I'll share this document with Flavian, and then she can share it with you all. I hope, do you have any more questions or clarifications? I wish we could do this class in 2 sessions rather than 1, because HIV is quite long. So if you have no more questions, we can end the class. So you'll bring me the attendance list, and if you have any more questions, I usually rotate in the women in Farm 4F. If you have any questions, you can let me know and I will clarify. Thank you.
Thank you, Dr.